All right. Very good. Welcome, everybody. My name is Dave McClellan. I'm the program manager for the Merge Collaborative, which is in partnership with the Building Maine Network and supporting the Maine Rural Healthcare Education Grand Rounds. We are very excited to welcome Dr. Jason Hine today. I will quickly note a big thanks to the Building Maine team, which is led by Dr. Anika Smith and Meredith Bullard. And they have actually helped recruit Dr. Hine today for this excellent presentation of time-efficient teaching. Just a few words about Dr. Hine. He's actually in the inaugural class of the Tufts Maine track some years ago. He went on to complete the emergency medicine residency at Temple University in North Philadelphia, where he also served as chief resident. And he joined the Southern Maine healthcare team in August of 2016, where he serves as the educational administrator. And so he looks forward to working through the Scholars Program and hopes to improve his and his colleagues' bedside teaching of residents and students at the Southern Maine Healthcare Emergency Department. So without further ado, I'm going to hand it over to Jason Hine. Welcome, and I will check in at the end of the presentation.
Excellent. Thank you, David. Good afternoon. Yep, we're a few minutes after noon here. I'm going to get my screen sharing up and then get started. You're all going to see each other for a moment, it looks like. And just to verify, you guys seeing my slides currently?
Looks great.
Fantastic. Awesome. All right, guys. So yes, I'm Jason Hine. I'm an emergency medicine physician by training, and I am now at Southern Maine Healthcare, which I think is going to be Maine Medical Center South in like 2 or 3 months. But in that capacity, I've worked with the residency program there for doing their community rotation, and from there sort of spread into other areas of the hospital as the medical director of education, where one of my major areas of focus has been faculty development for us as a hospital and supporting our preceptors in educating not just residents, but we have a pretty strong tie to UNE as it is in our backyard. So time efficient teaching is definitely something that we focus on in our faculty development, and I'm happy to be able to chat with you guys here today about that. And as David mentioned, I'm a Colby grad and then Tufts and then Temple and then back up here. I've been through the MITE program, and I do at the intro of this definitely have to give a huge shout out to Bob Trowbridge, who's really the original author or is the author of this topic and talk. And he graciously has allowed me to adopt it, modify it, and but huge appreciation to him, not only in raising me as a clinician, but also for this topic matter specifically. So some of the terms and conditions of the talk here we have to put forward to you, including no conflict of interest for me, no important financial relationships. And then most importantly for you all, getting your CME credits. So texting 90615, and then what you're texting is kind of verbose. It looks like it's Maine Rural Health Education Grand Rounds. So make sure that you're getting your credit for attending and being participant here today. So quick goals and objectives of what we're going to be talking about. I'm hoping to identify and or list that you're able to identify or list specific teaching techniques that may improve the efficiency of your work as an educator and as a clinician. And then number 2, I think, is more important because it's the actionable one, is to actually physically create a plan using 2 of the techniques we're going to talk about today to improve your teaching and doing so efficiently. Because we'd all love to have infinite time to teach, but clinical responsibilities obviously can kind of pull us away from doing so. So hopefully at the end of this, you have an actionable plan of using some of what we're going to talk about to feel like you have the time to be a great clinical educator. So I'm going to try, and if we fail, that's okay. We can always just shout out if people are comfortable doing so. But if you're on your computer, you can use the QR code with your phone, or in the chat is the link as well. I'd like you to try to do this poll everywhere with me. The option also of texting 22333 with Jason Hine 524 space and then your answer. And the question is, what are my major barriers to being a good clinical educator? And I'm curious what our responses are and then how they're going to compare to what we're going to talk about today. I'm going to give people just a moment to do that. and then try to hop over to here.
Jason, I clicked the link and it says waiting for Jason Hine 542's presentation to begin. Perhaps I did it wrong.
All
Oh,
right.
there it
How about
goes. Now it's activated.
All right. Sorry about that, and thank you. And you guys are seeing that as perfect. It's up there as well in the corners for potential responses. But David, please let me know if it's not working. Question again, what is your major barrier to being the best clinical educator you can be? Organization. Nice. See clinical coming up as a big common theme. We'll schedule. Interruptions. Yep. Give it another 30 seconds or so. It's still coming in. Great. Location. All right. Well, thank you for guys for doing that. As you can see, we have a few items on there that are all about the same size, and then clinical, just giant clinical coming up as a common thread or theme. The needs of the hospital, the needs of your patients, and you can see that in a couple other areas, interruptions, being pulled away, full schedule, space and quietness to be able to do so. That's an interesting and valuable one as well. So very cool. Thank you guys for doing that. It looks like it worked relatively well. So comparing a lot of that to what we're going to talk about today. So the major barriers that have kind of been discussed about in the medical education literature, and we're going to talk about today, are one is that they cannot be assistive to me in a lot of those clinical responsibilities, that their presentations take too long, that they are overly involved, interested, and have tons of questions for which I just simply don't have enough time to give the 5-10 minute answer for each question that comes up. And then the kind of grab bag one there is there's no time to teach. So focusing on that first, we'll go in order. They can't help me. So when we talk about this stuff, the first thing I would say is, truthfully, put the student to work. And when we meet as groups, I ask our attendings, our preceptors, what is the biggest time suck to your day? What is the thing that takes the most time, that has least sort of value added for you as a care provider, as an individual in medicine, within your relationship with the learner, with the patient, and take those items and use them educationally. And we all have been through, obviously, medical education, whether it be medical school, nursing school, etc. We all had to learn how to and to do these things. And so while this is a probably mundane or time suck element for us as med students, we have to learn how to do, get vital signs, how to get old records, how to educate patients, how to do a medication reconciliation. Some of these things that for us can be offloaded to the learner are very valuable to the learner, and recognizing that this is something that isn't just scut work, but something they need to have in their tool belt or their toolbox is important and can free up time for us, is a valuable way to make teaching a little more efficient for you. So the next one is their presentations take too much time or they take too long. And if we think about the structure by which we get learner information or presentations, it is incredibly inefficient, right? We tell them to go see them. They research the patient, spend quite a bit of time going through all of that because they're not as efficient, certainly, as we are in that capacity. Then they go in and they get their history, present illness, the family history, the great uncles, second cousins, medical allergy list. They do a physical exam, they come back and they present all of that to us. We go back into the room with the patient and we do it all again, which is pretty insane that that's the structure by which we've kept medical education going in that way. So bedside presentations really is the idea of by the time that they get a lot of that information, they are doing the presentation to you as a preceptor in front of the patient. And that might create a pause for people in some capacities. And so let's dive into that a little bit here. We have some perceptions about what bedside presentations might be like and how they might be perceived. So the first is the preceptor. And this is actually an area in medical education where there's decent data. You might have some concerns or reservations about it, but in the studies that have evaluated standard, the old sort of what I would say old or inefficient way of doing it versus the bedside presentation way, preceptors were found to have a higher perception of the patient and learner understanding of the education that's being delivered or the endpoint of the patient's care. They felt that there was an improved sense of patient involvement, obviously, in their own care, which led to that understanding. And they did not feel like there was any deterioration in their ability to teach the learner. So preceptors actually found that they liked it and preferred it over the other approach. How about the patient? The patients actually were seen to have a higher degree of satisfaction in working with a learner. They had a preference for this style versus the sort of older or traditional door jam or conference hall style that we're used to doing. And incredibly important for me in this data was that there was no change in their degree of confusion or discomfort from the patient's perspective. And that definitely comes up if you think about a third-year medical student going through their differential diagnosis. Well, they might say, you know, I'm concerned about cancer, and we have to talk about that in front of the patient with the precept, as the preceptor. There's two elements to that. The first is oftentimes if the medical student is bringing it up as part of the differential, there's a reasonable probability that the patient had a similar concern through Dr. Google or WebMD. And so our ability to address that ourselves can help put the patient at ease. And if they did not have that opinion or perspective, when it's brought up and discussed about, it shows a greater degree, the patients had a greater degree of confidence knowing that we really overturned all the stones or we were really thinking critically about them and their care. And the other really important one from a patient perspective is they actually had an increased perceived time with you, the preceptor, which is magic, right? We're always trying to make time out of nothing. Always talking with our learners or residents, you need to sit at the patient's bedside. It's 1.5 times more perceived time with them. This is another example when we can make time out of nothing. And then how about the student? Well, this is actually the one. So we said preceptors like it, patients preferred it. Students, maybe not so much. When they first started doing this, there was in the data, they're shown that there was a definite decrease in comfort. There's a little bit of a learning curve to it. But when students were integrated into it and had some time with the bedside presentations technique, they actually preferred it over the door jam or hallway style. So at first uncomfortable, but then a gained preference for it. So that's bedside presentations. A modification or another sort of version of that is what's called bust into the exam room. And this is the version that I do now as an emergency physician, just because of time management and trying to coordinate all things. So in bust into the exam room, the learner goes and sees the patient. You go complete another task, whether it's a sew laceration for us or evaluate an ankle sprain or something that generally is not going to take a longer period of time. And you tell the learner, go start with Mary. When I'm done doing X, I will join you in Mary. You tell me where you are and present her in front, present in front of her to me. And then the great part about this is then I can join you and we can work on the physical exam. I can watch how you do a history, or we can do patient education together. So you can control the encounter length with bust into the exam room, which I think is super, super valuable, especially in our area of emergency medicine. And then the other two, I'll sort of lump them together, focusing the learner and setting expectations. These are two other tricks that can decrease the sort of the presentation or patient learner interaction time frame. So for example, if you have, go back to Mary or Chatty Cathy. Chatty Cathy's coming in for her evaluation of her blood pressure and how it's being controlled. You know Kathy well if you're working in the outpatient setting, and she can have a verbose or tangential history giving. So letting the learner know, we're going to see Kathy, and today we're going to be talking about her blood pressure. We're going to focus specifically on her side effects related to her medication and her blood pressure log. My expectation of you is that in the 15 minutes while I'm doing something else, you're going to review how the medication has been treating her and her blood pressure targets. And that can also help rein in these longer patient encounters or patient presentations. All right, and then on to the next area. So note, they cannot help me. Their presentation takes too long. And the third here being the learners ask too many questions. So there's a few structures that can sort of combat this in real time. The first, which I think is a little bit of a gimme, but it's important to say aloud, is obviously we need to encourage our learners to be self-directed in their seeking of knowledge. We're lifelong learners in medicine. We always talk about that, but letting them know that if you come to a question, I may not have the opportunity to answer all of the questions in real time, but if you have a question that arises, I want to give you the tools and the ability to answer these on your own accord. So setting that expectation up front is an important part. And then some more tactile or more actual, I guess, ways of approaching the too many questions that they may have. One of which is the educational prescription. So I like to, teach our faculty about that. We have these little mini tearaway pads here. I'm not sure if it's showing up on camera very well, but we don't really have the actual, desktop prescription pad any longer. Most of this is done digitally these days. So simple little tearaway pads. This is a 3x5 that we're providing our internal medicine or OB or other groups with. So when they're on shift with a learner and they come to a question where the work of the day just doesn't allow you to spend the 15, 20 minutes, whatever it is, to answer the question, you can take one of these pads, write the question, and then give them one or two options for where they might find the answer to the question, tear it away and provide it to the learner. Obviously, very importantly, we come back to that either tomorrow or later in the day and review what they found. So educational prescriptions, I think, is a really nice tactile way of addressing. We can't answer this question right now, but it's important and we'll get back to it. The next is a notebook, and different groups I feel like have done this differently. We have these little moleskin notebooks here that can either go to the learner or go with the preceptor. And in this way, they're just going to have, the date and write their question sets or the questions that come up into the notebook and keep it in their white coat if people are still using white coats where you're practicing. And then this is creating a catalog that at the end of the day, you can review with the learner. And the very nice thing about this is as questions come up, if you're answering each one in real time, you're just never gaining momentum or efficiency in patient care. But if you catalog them and continued with the day through patient education or other ways, you'll find that many of these questions are getting answered in actual clinical practice, decreasing the amount of time you need to spend answering or addressing the learner's question. So at the end of the day, at lunchtime, when you guys are finishing up, whatever time point it is for you, take the notebook out, review it with the learner, say, okay, we answered this when we went over Chatty Cathy's blood pressure medicines and their side effects. These two questions are unanswered. Let's make an educational prescription, and we'll come back to it at the start of tomorrow. So two ways that can kind of pair nicely together for you to address the onslaught of questions that might be coming from an active learner. And we want lots of questions, right? We want engagement, but we need to be able to sort of rein it in or manage it. And then when they're asking lots of questions or they're very actively engaged, sometimes if you're very behind, you have a very active day, things are just not going efficiently as you might want them to. There's sort of a pop-off valve, I would call it, in these alternative learning experiences. And these are really a means of giving something important and valuable to the learner to allow you to continue to provide clinical care. So what are these learning experiences? The first year is called a structured reflection, and they can be diagnostic or treatment-based. but mostly I use them in the diagnostic realm. So here's an example of that on the screen. And again, we've taken these, I've laminated some of them so that they can just exist in the department or at the charting space. The learner can use a dry erase marker, or we printed out, obviously paper ones ad nauseum, so they can just have them and keep them in their pocket as well. And the way this works is you're gonna, you can see you put 3 conditions that fit what could possibly be happening with this patient that you just saw in this hypothetical with shortness of breath. All right, so they could have CHF, they could have COPD, they could have a PE. And then you go over the concordance, the discordant, and the things that are missing. And there's actually data around this that shows that this improves the clinical reasoning or logic skills of the learner. Even if you don't go back and review this with the learner, they're still developing that skill. Obviously, we recommend if you're giving them work to do to spend the time to review it with them when the dust settles. But this is a great tool in your toolbox when you say, I need to go and do my 15 charts I'm behind on. Why don't you do a structured reflection on that patient with shortness of breath? And then another one, this one I think is okay, having them go and prepare for the next patient. I think that's a very easy, low-hanging fruit one that doesn't require a lot of structure on your end. And that's there. I think it has the potential to be sort of a go do something else. But if you're giving them specifics, like we said, specifically setting expectations, then that can be valuable as well. And the other ones that I like to recommend are the diagnostic or therapeutic schema creation or researching. And researching, I think, is probably where I've led most, because writing a schema kind of takes a long time and needs more longitudinal, but we'll dive into that. So this is clinical problem solvers. And as an example, I don't know if I can't see you guys currently, but if anyone has used clinical problem solvers, go ahead and throw a thumbs up or a comment in the chat, because they are fantastic. They have a lot of different structures for thinking about disease processes. So when you get behind and you need to go and see the other patients that have been waiting 45 minutes for their visit, whatever it be, you can say, all right, that was interesting that we just saw Rob, and his hyponatremia seems to be an ongoing issue. Why don't we spend some time, or you spend some time looking at the different etiologies or structural frameworks for hyponatremia? You can offer clinical problem solvers. There are others as well. There's the rational clinical exam, among a lot of other ones, and I'm happy to give you guys references in that capacity for them to look up and understand a complex problem like pancreatitis or hyponatremia in a visual way. And having them start with researching and find is great. If you can move that further into generative learning, which is a cognitive science term, from finding to creating a schema, that would be even better. But this is a great way to give them something important to do related to a patient, so it has some stickiness to their long-term memory while allowing you to do other work. And the clinical problem solvers is great as well for the current adult learner, because they have very short podcasts as well, and they're pretty graphically engaging. So they're catered to that sort of attention span that we seem to have shrinking and shrinking every day. So kind of in summary of all of this, when you come to the question or you feel like your concern is they cannot help me, I think the solution in many ways is put them to work, or have them do the things that are generally a time suck is the term that I use, a time suck to you. So medication reconciliations, definitely a time-intensive endeavor on your end, and something valuable for them to do. Problem lists, vital signs, old records, all of these things that we all needed to learn and develop that skill in, but is no longer valuable for our relationship with the patient or gives us meaning as providers, can be valuable and important for them. And I should add the caveat to this, that this is catered toward the UME world, right? It's going to be less so for resident education, but it can be as well. But a third-year medical student is ideal for some of these elements of skills that they need to develop as they come into the actual clinical practice, the patient engagement side of their 4 years of education, to use some of these things that can offload you significantly. When you think about their presentations taking too long, The one that I really love is the bust into the exam room, which is a modification of that bedside presentation. I think the bedside presentation plus minus the bust into the exam room is a great way of controlling the length of the encounter through the learner, and gives us a lot more of that direct observation of the learner in their either history getting from the patient, their physical exam skills, which we may not find otherwise if they are seeing them, presenting them, or going back in together, kind of that traditional approach. You can also focus the learner and set these expectations explicitly. One important part of that I think is worth mentioning is you can target this to the elements that the learner is either struggling with or focusing on. So when residents come through, or even medical students come through, and I'm doing a shift with them, at the start of the shift, I'm often asking, or trying every time to ask, what are we working on today? And if it's the neurologic exam, then we're going to try to focus in that area. And you can sneak that in or involve that in patient care in the emergency department. That's not necessarily related. If someone's dizzy or there for another complaint, we can say, all right, go and see the patient. When you get to the point of your neurologic exam, come and find me. We'll go back in together. You can present the patient and we'll do the neuro exam together. So it can make it really, you're much more in control of the patient encounter, its length, and where you're engaging with the learner than the traditional approach. And then they ask too many questions. We have sort of 4+ solutions to that. Certainly starting with letting them know that they are part of the medical community. We are all lifelong learners, and developing the skill of self-directed learning is going to be important for them in the long term, but also for this rotation. I like to have the educational prescription pads in our pocket or at our charting area, and the notebook for the learner so that they can catalog their questions throughout the day, and we can review them at the end of the day, oftentimes crossing things off, which are just questions that are answered through patient care, patient education. And then when you really need that extra bit of time, these alternative learning experiences can be a really nice pop-off valve, so you can go and be the maximally efficient clinician we all try to be, and they can still get important education through that structured reflection, preparation for the next patient, or looking at or creating a schema. So with all that in mind, I'm going to stop sharing. Come back to you all here now. David, I'm going to partially hand it back to you, I guess, but I'm happy to now answer any questions, or I think importantly as well, if people have had success or failures in any of these areas, would love to hear about that and sort of spend our, our Q&A session really brainstorming what's worked and what recommendations people might have. Kelly, go right ahead. You're on mute. Kelly, you're muted. I'm sorry. I see your mouth moving, but you're muted.
What I was saying to myself was that I precepted in resident clinic for 30 some years. And I'll be honest with you, when I logged on, I'm like, I am not going to learn anything, but here I am. But I was wrong.
I appreciate that, Kelly.
So thank you for that. And it's a really good self-check on my own humility. One of the things I really liked was that idea of with the printed, when you're sending residents off to students to do that. I thought that was a great idea, and it's not just busy work. So I had never seen that before. So thank you for bringing that up. I thought that was great.
Problem. And yeah, we have a ton of them we've printed for our groups, but I think, David, after this, I can give you just that document and people can print, 15, 20 of them, have them there with your notebook, with your prescription pads. And I think having that physical stuff just takes away that one extra barrier of that implementing what we're learning today. Jen?
Hi, thanks for that, Jason.
Yeah.
I was just going to mention, to piggy off of Callie's point there, that tool, we call that the DART tool for the tough students, the Diagnostic Assessment Reasoning tool, and that is actually embedded into their curricular responsibilities. So specifically, any student that comes to any of the preceptors from Tufts will be very well aware of that. And in fact, they have to do a required number during each rotation. So they would welcome an ability to kind of, check off a task when that's needed for a sort of time decompression. So thanks for sharing that. And just want to echo your point that it's not just busy work, that it does actually help their diagnostic and clinical reasoning skills to move them along that continuum. So I'm glad that you're using them at Southern Maine as well.
Go ahead, Shelley.
Hi there. I want to thank you for the tools. I don't see residents. I'm part of an interprofessional group. Jason, I think we met a while ago through Stephanie, but I can see the utility of using some of these strategies for team-based learning as well. Because one of the things that happens is that questions and ideas and thoughts get lost in the team process, and having something concrete like the educational prescription pad and a notebook, like a physical notebook, which is incredibly old school, but really valuable for them to catalog what it is that they're interested in knowing and from whom. So I want to thank you. You gave me a lot of great ideas.
Thank you. Karen.
Yeah, hi. Thank you for that presentation. I really enjoyed it. I'm a surgeon at Mercy, and I'm a Tufts, adjunct faculty. I usually have an LIC student and a fourth year rotation. And I'm curious, what I've been doing LIC for probably 10, 11 years or so. And the trend I've seen, and I don't know if it's just the particular students I've had, but I feel like earlier on, the students were better about if I just said, hey, pick a topic for next week and read about it, they would come in next week with a topic they read about, ready to talk about it. And I feel like lately the students have needed more structure. Like it's hard for me to just, be kind of, I don't want to say ambiguous, but it's hard for me to throw that out there and really get a good bite on it. And I'm just curious from you or anybody, like some of the strategies you presented, I mean, it's work for me too, right? To write out prescriptions or maintain a notepad or all that kind of thing. And, how much do you expect from the student to maintain the notepad or take responsibility for the topics that come up for discussion versus how much do you put on yourself to follow up with them about it?
That's a great question. It's probably a group one if people have opinions or perspectives, and so see if anybody in the group has an answer or opinion. Jen, yeah.
I have an opinion on that, Karen. Thank you for bringing that up. I work very closely with the medical students in my role in Maine Health, and I think that there are a lot of reasons for that. I'm not sure over how many years you have seen this, but certainly I will say that pandemic learning has made an impact on the students. Their learning in undergrad was, a different sort of um, experience, and so they're coming into medical school maybe not as ready to be to make that transition into adult learning. We are very keenly aware of this and actually have targeted interventions in our curriculum to work with the students around what being an adult learner means and strategies for them to come along in that. It's definitely an issue. I will say, I think it's a little easier to counter that than maybe what some of us realized. Another upside sort of with this generation of learner that's coming up is they do take pointed feedback fairly well and respond to, these are the expectations that I'm giving you and I expect you to follow through on those. So I think sometimes we feel badly setting up a learner at the beginning of a rotation to say, here are my expectations for you. So in your example, Karen, come up with a research question and we'll talk about it next week. Or if you do decide to employ the notebook technique, saying to the student, I expect you to take the ownership on that. And I think that can save a lot of time and be helpful to bring them along that continuum. You're not alone in your observation, so thanks for sharing that.
I agree with you about pandemic learning. That's what I assumed. I mean, that's the time frame of kind of when I've noticed it. And I agree with you too that I have been asked for feedback more times in the past 2 or 3 years than ever before that. So I guess I should put those things together and try to get them to modify their approach through the feedback. But yeah, I just kind of, after the last LIC ended, have kind of been thinking, okay, I already provide a fair amount of structure, but feeling like I need to provide even more as time is going on, like for the coming year. And I think, maybe it would be a good idea if I was really super explicit at the beginning and maybe ask them for the notebook and just be even more clear. Yeah.
And I think the notebook, sorry, real quick, the notebook is can counter both sides of the spectrum of a question realm for learners. So the overly asking, which is great, we'd rather have that, right? But I've had the feedback from a lot of our preceptors of, I don't have that problem. I have, sitting in the back, not asking any questions. And so when they're handing these notebooks out, starting with the date and a 1, 2, 3, 4, 5. The course of the day, if we haven't generated 5 questions, then I don't, that would be the goal. It should not be possible to go through a day of seeing patients being active in care and not come up with 5. If you come up with 3, sure, we'll get to 5. But my expectation of you with this notebook I'm handing you is that you're going to generate a set of questions and we'll review them at the end of the day. So go ahead, David.
Thank you. I just wanted to call out Annie Durthick put in the chat a recommended podcast. I'm just saying it verbally for those watching a video recording and can't see it. She highly recommends it. It's the not-otherwise.specified-podcast nejm.org. I will put that link with the resources that you also share, Jason. I'll put it next to the recorded presentation so folks can access that. Seems really relevant for what everyone's talking about.
Yeah, I'll just add a description that it is the host of the podcast is a cardiologist. She is involved in graduate medical education. She's been blogging for a long time about cultural shifts in graduate medical education and how this has shaped the clinical learning environment. And she transitioned her blog to a podcast and is talking to anthropologists and experts in GME and teaching about how generational shifts, cultural shifts have really radically changed the learning environment in GME, and it is exquisite. The episodes that I would highly, highly recommend if you don't have a lot of time are Tough Love and OK Boomer. They touch on the topics that we've been talking about in this grand rounds, so it's really good.
Thank you for that.
Yeah, thank you. When I think back to the amount of effort that was put in by attendings or residents who were teaching me, which was at Tufts in Boston like 22 years ago, I feel like I put in so much more. It's just a totally different expectation. I mean, pandemic aside, it has changed a lot, I think for the better, but I'm glad to hear that I'm not the only one sort of experiencing this in real time.
And I think too, Jason, your talk was great tips for you and me. And I thought that list at the beginning of things that medical students can do was also very helpful for me. Just the rules keep changing about what medical students can do. And I think some people think they can't do anything. And I thought that was a great list of things that they can do. So I think that's really important to change our mind shift that only residents are helpful. Many of the things you listed really in terms of medical students impacting the clinical flow of the day. I think that's a really big barrier, to be honest with you, when you're thinking about UME and GME. So I really appreciated that as well.
Outstanding, folks. Just we have time for one or two more questions. I certainly want to give lots of space for everybody before we go into our closing information. Jason, thank you so much. Just an outstanding presentation. Great to have you with us. And thank you everyone for joining us. I'll give you a quick teaser for what we will have next month. On May 10th, we're going to be joined by Dr. Cheryl Seymour from the Maine Dartmouth Family Medicine Residency. She's a faculty there and also works, of course, at Maine General. And she also works with the Maine Mobile Health Clinic. And so her presentation is going to be structural competency in the migrant farm worker health. And so it's going to focus on introducing structural competency, but with her work with the Maine Mobile Health Clinic as an example of how she teaches learners in a farm worker health setting. So it certainly ropes in rural medicine, which we're very focused on, but a really unique thing to talk about, really a concept that works for all educators. So we really hope you can join us. It'll be the same link, same time, just next month. And if anyone has questions, please don't hesitate to reach out. You can reach us through the Merge Collaborative website, through Building Maine Network website, which is clinicalrotationsinmaine.org. And of course, we have the iHELP-Maine learning platform, which can be accessed through both with lots of resources on there. So all of this will be on our website. Please check it out. And if anyone has questions, you just reach out and we'll hope to see you next month. Thank you.
Thank you guys. Thanks for joining. Bye all.